Welcome everyone to the first of two reflections events hosted by Birth Companions. I'm Birth Companions Director Naomi Delap. Today we're considering the findings of the MBRRACE Saving Lives, Improving Mothers' Care report on maternal deaths, which was published last month. And in particular, what those findings tell us about women who have involvement from children's social care, and how we and others are driving action in light of them. In just over 2 weeks' time, we have another event focusing on the findings of the review of care for women who've recently migrated to this country. And you're obviously very welcome to join us for that one as well. And I'm sure that Catherine will be sharing details of how you can sign up for that, perhaps later on in the chat. So I'm going to tell you a little bit about Birth Companions just before we get started. For those of you who don't know us, we're a charity that supports and protects women who have their babies in very difficult and complex situations. They might be in prison or on probation. They may be caught up in the immigration system or have involvement from children's social care. Evidence shows us that what happens in the first 1001 days from conception to a child's second birthday lays the foundations for the rest of their life. But for thousands of mothers in the UK, the challenges that they face during this critical period are creating huge risks to their own health and well-being and to the life chances of their children. Now, we've seen that systems and services don't always understand or meet the needs of mothers in these situations. In fact, often they're let down. So Birth Companions exists to fight for equity and justice for these pregnant women, mothers and their babies. And we'll know we've achieved that when all women have the best possible experience of pregnancy, birth and motherhood, whatever their circumstances, that each woman attains the best possible health and well-being outcomes for herself and her children, and that our law, policy, services, systems and guidance meets the needs of every woman and baby. Right, we're going to keep this session brief because we know everyone's really busy, but we do hope to have time to consider a few questions and some reflections at the end. So please do share questions in the Q&A stream and reflections in the chat as we go through. We really want to hear your thoughts, your experiences on what we're talking about. However, we do intend to organise further opportunities to discuss these issues. So today is not the only day, and we will be happy to pick up themes and specific conversations after this meeting too, and also share what we're planning moving forward. So thank you very much once again for attending. I'm now going to hand over to Kirsty to talk about the MBRRACE findings and what needs to happen in response to them.
Thanks so much, Naomi, and thank you to everyone for joining us today. It's lovely to see the names popping up in the chat, some familiar friends and supporters and allies, but also some new names as well. So I'm excited to hear what you all have to say, either today or in follow-up conversations. We've been involved in helping to develop the lay summary for the MBRRACE maternal deaths report for 5 years now at Birth Companions, and we've had a focus on exploring all forms of health inequity that come up in the report, but in particular we've led a sort of shift in the level of focus that is brought to the number of women who die while known to social services in that 5-year period. And that number has increased very significantly. In the 2012 to 14 report, it was at 12%. And in this most recent report, which covers 2020 to 2022, it has risen to 22% of the women who die. That's really, an incredibly significant rise. I think we all are very aware that it is likely to be the tip of the iceberg, really, because there are some issues with how that involvement is captured in the data. And the data itself doesn't disaggregate between adult social services and children's social services. But what we know is that by looking into that a little bit deeper, and we'll talk about some current research that we're involved with later on, the vast majority of those women have involvement from children's social services. They are women who are at risk of having their baby removed at or shortly after birth, or who are already dealing with the trauma of that removal when they die. Work was done in the MBRRACE report published in 2022 to look at this group of women a little bit more, and the deep dive that was conducted at that point showed that 11% of the women who died by suicide had a child removed from their care or were in active care proceedings, and 59% of the women whose deaths were linked to substance use were in that situation. Looking more widely, the number of infants who are subject to care proceedings has also grown significantly in recent years, and that's potentially one of the reasons why we've seen the rise that we've seen in MBRRACE. There is also a huge variation in the rates of proceedings and the outcomes of those proceedings for newborns and infants around the country. We've been campaigning for many years for improvements in the care for these women and their families, but unfortunately, despite the best efforts of us and many others in this space, their needs are still largely absent from health and social care policy. And we know that many of the women are, for example, struggling to access the mental health support that they need at this very, very difficult time in their lives. What that stacks up to is that there are many women who are navigating what is one of the most traumatic experiences imaginable, largely alone and unsupported. And that's another reason why, we can see there may have been such a significant rise in recent years. We've got to think about the context of austerity. We've got to think about the lack of early help and support for mothers in these situations. So that's why we're not really surprised by the MBRRACE figures, although we're deeply saddened by them. In fact, I'd argue that they could easily be much higher than they already are, given what we see and what we will continue to see without really radical change to policy and practice. I also just want to note that the MBRRACE figures go up to the end of the first postnatal year, so the child's first birthday. But as Naomi set out at the start, at Birth Companions, we have a focus on the 1,001 days, the first 1,001 days from the point of conception up to a child's second birthday. And we would, strongly encourage everyone to be thinking about social services involvement across that 1,001 days. If we're serious about improving care and support for mothers in these circumstances, we need to be mindful of the fact that the child's first birthday marks a year since their birth, but a year from a baby's removal will likely be marked, a few days or weeks or months after that first birthday. And that's an incredibly critical time. So it's not good enough in our eyes to just focus on that postnatal year. We also need to be thinking beyond that for many reasons. If you are interested in the data around social care involvement among newborns and infants, Catherine, if you don't mind ticking on to the next slide, there's a lot of evidence that has been built and shared in recent years. We're lucky that the Centre for Child and Family Justice Research at Lancaster and the Nuffield Family Justice Observatory have done so much to build that evidence base and to establish a stronger focus on this critical period. But we need to know a lot more still. We need to know more about what is happening in the lives of the women who die during and after care proceedings if we are to shape improvements in care across health and social work to reduce the risk of that death, not only by substance use or suicide, but also as a result of domestic abuse, for instance, and homicide. So that's why we're involved in a really vital and exciting piece of work that colleagues at King's College and National Perinatal Epidemiology Unit at Oxford are working with us on, and Kat de Backer will tell us more about that shortly. But first, just to put things in a little bit more context before we hear about that new work. There's no doubt that the notion that your baby might be removed from your care is a terrifying one, even if that likelihood is pretty slim. So I think when we're thinking about these issues, we have to be very mindful that women are very scared about being honest about the nature of what they're facing in their lives, whether that is domestic abuse, mental health needs, poverty, use of substances as a coping mechanism, etc., because of the fear of social services getting involved. And that is a huge hurdle for services of all kinds to overcome. Many women come to maternity care holding these fears and with a deep mistrust of services, particularly when they have been in care themselves as a child. And we know that that is a well-trodden path, unfortunately. The gaps in this space are really significant. Early help services have fallen away, and there's been a real shift towards late intervention, very crisis-driven intervention in children's social care. That's largely due to a lack of funding for local authority services. And it means that women and families are struggling on without support for a very long period of time often, until they reach that crisis point in which a decision to remove appears to be the only option. And that's a horrendous cycle, one that we really need to break. And I'm hopeful that the government is really engaging with at the moment. Crucially, when a baby is removed, women often experience a complete falling away of any services that have been around them and their family. And particularly that applies to mental health services. So in most areas of the country at the moment, if a woman is in receipt of support from perinatal mental health services and has her baby removed, she also loses that perinatal mental health provision and is rerouted onto generic adult services. And so it's no wonder that in 2022, the MBRRACE report found that in several instances, infant removal had led to an escalating pattern of mental health need, substance use, and domestic abuse. The gaps haven't gone unnoticed, of course. The lack of mental health provision for women in these situations was recognised when maternal mental health services were established, and they were tasked with providing support to women who experience loss as a result of separation. But the excellent work done by Maternal Mental Health Alliance recently, unfortunately, shows the extent to which those services have been unable, in the vast majority of the country, to develop or start up a pathway for women in these situations, largely because of a lack of resource, often a lack of specialism, or a lack of motivation and impetus at local and regional levels. And I think MBRRACE reminds us that gaps in provision can and do cost lives. So this is a critical point for us. If we move on to the next slide, please, Catherine, just briefly to flag up a piece of work that we did with SANS and Tommy's Policy Unit and the Health and Wellbeing Alliance recently. We did some research looking into the health, physical and mental health needs of women who have social care involvement in the 1001 days. And women spoke very powerfully about the lack of mental health support specifically. Some quotes on here. One that always really strikes me is a woman describing that there is grief therapy. My children aren't dead, but they are dead in my life. They are dead in my world. They've been with the foster family for 5 years and they're biologically mine, but they're not mine. There isn't anything available to deal with feelings like that. And I think when we hear, as we do very often, unfortunately, experiences like that, we can understand where these MBRRACE statistics are coming from. So that's why we published the Birth Charter for Women with Involvement from Children's Social Care last year. This is a comprehensive set of principles. I know that many of you will have seen it, and many of you have supported it, so we're really grateful for that. It's a set of principles, a framework to inform policy and practice across health and social care and the family justice system. I will let you digest it in your own time, but one of the key recommendations that we pull out at the end of that report is for the creation of a joint national health and social care pathway, something that can really engage with and tackle head on the multi-agency issues and weaknesses that we see across the system that have such an impact for women and their families. We know there's a lot of interest across different parts of the country in embedding the principles of our Birth Charter and building coordinated pathways of care, having great conversations with several of the people that have joined us today on that. But we also really need national leadership on this. It shouldn't depend on where you live. National government, are talking to us about this and to our partners in this area, and we're really hopeful that the needs of women who have social care involvement will be lifted up the agenda at a national level in coming months. Our newest project, our newest service at Birth Companions also embeds the principles of the Birth Charter. The EASY project is a new service in Hackney in East London. It was designed specifically to support pregnant women and new mothers who have involvement from children's social care. We co-designed this service in partnership with over 40 local organisations and a really incredible team of women with lived experience of social care involvement. Those women are still involved in the project now that it is up and running. They shaped it from the outset. They gave it its name, but also now they are involved in shaping the delivery and drawing some of the learnings out of that service provision. What the co-design process for the EASY project told us very clearly in engaging with all of those partners and stakeholders was that there was a need for a service that provided continuity of care, relationship-led care that could work independently from, but in very close partnership with maternity provision, with the social care team in Hackney, and with the many other services who wanted to, could, should provide support. But women needed an individual who would walk that path with them, which is why it has a sort of navigator model at its heart. They also needed a service that wouldn't fall away soon after the birth of a baby or soon after the removal of a baby. They needed a project that recognised that not all women who have issues with their communication, with their understanding, meet the learning disability threshold, but they do need someone to make sure that they understand and can process and can respond to a huge amount of information being shared and a lot of questions asked of them. It also takes into account the fact that there is a huge amount of crossover between drug and alcohol services and domestic abuse services and housing and social care involvement, and a lot of practical support required as well, given that a lot of women are navigating this with very limited financial resources and very limited social networks. So the EASY project is a 4-year pilot that is up and running. We were glad to share some early insights from the service with local and national stakeholders recently. The model is, as well as providing some excellent support to women in Hackney, it is designed as a learning and development model as well, so that it gives us an opportunity to see where the weak points are, where the good practice can lie, and to share that learning across wider systems to support regional and national improvement. And I hope to feed into the development of a national pathway. that's all part of building the evidence base around multiple complex needs and experiences, but we need to build that evidence base even further. So I'm very glad to hand over to Kat now to talk about the work that we are involved in and that she is leading on this area. Thanks, Kat.
Thanks so much, Kirsty. So yes, it's a really honour to be part of this reflection event. I've worked with Birth Companions since the start of the Mums at Risk study, which is an NIHR-funded doctoral research study specifically looking at the maternity experiences and perinatal outcomes of mothers who face removal of their infant through social care proceedings. And short, that is the Mums at Risk study. It very much comes from clinical practice and having worked with women in my capacity as a midwife who were having social care involvement and the complexities that brought with it. And that led me to sort of apply for funding to look at this more in detail and specifically looking to what improvements we could make to make maternity care journeys for women with social care involvement a bit better. There's a first publication just there in terms of the sort of the philosophical pinpoints of the study and using reproductive justice theory to really carefully think about the role of midwives in that. But if we can go to the next slide, the study is actually consisting of different parts. So I started with doing a systematic review, looking at all the existing qualitative healthcare evidence on having child protection agencies involved during that perinatal journey, not just from a maternity care point of view, but also in mental health services. That paper has been published now, and there's a link on the Birth Companions website to that in case it is of interest. The study is very much using mixed methods research, which means that I'm using different research methods to build this deeper understanding of the problem. And as part of that, I'm using a linked database of maternity records and mental health records to really understand who are the women who have contact with social services during pregnancy. What are the reasons that they have social care involvement for? And are there women that we perhaps should be aware of that are currently not being supported in the way they should? And so that is done by the Elixir database, which is a South London database of linked pregnancy and mental health care records. I'm also conducting some interviews with women who have lived experience of infant removal to explore their expectations, their care needs, and just hear from them what recommendations they would formulate based on their own experiences of having social care involvement through pregnancy and then having a child removed shortly after birth. And I've also completed a confidential inquiry of MBRRACE data of women who died during pregnancy or the year after giving birth when social services were involved. And the idea is that we use all these different components and all these different results to bring it together and format it into research policies research results and policy recommendations. And all along of the work, I've had this incredible group of women with lived experience of infant removal that have been involved in like the very start in sort of thinking about what questions, designing the study, designing sort of interview schedules, helping to interpret some of the findings. They've been an absolute integral part of this study. And they'll help me as well to bring these all together. And then we'll take it to some perinatal healthcare professional forums just to sense check if those policy recommendations make sense. Now, given that we're talking today about the MBRRACE findings, I just wanted to spend a few more minutes discussing the MBRRACE work that we've done with a specific focus on social care involvement during pregnancy and the year after birth. Next slide, please. Yeah, so thank you. So as Kirsty mentioned, we've seen this rise of social services involvement in women who died during pregnancy and the year after birth in the last decade. And as Kirsty said, these numbers go up, but there is not always the same granular detail in the MBRRACE reports on a yearly basis. So we were given the opportunity, together with the MBRRACE team, obviously, to do a deep dive in some of the case notes of women who died during pregnancy or the year after birth. And we looked at 47 sets of case notes of women who died either in pregnancy or after giving birth, who had either their child taken into care or were having still ongoing social service involvement with their child still in their parental custody. And the main purpose we wanted to achieve was we wanted to understand what that care was like that they received, and whether or not we could identify some areas for care improvement. There's also going to be some sort of more granular descriptive statistical analysis on the whole cohort, so not just the 47 case notes of the women that we included in the sample, but all of the women that died during 2014 and 2022, which was 412 women who died during that period, who had contact with social services, which is actually 24.3% of all the maternal deaths in that same time period. Now, I can't, as much as I want, I can't go into much detail about the actual findings, because we're just at the end of sort of doing our analysis and sense checking it with a few stakeholder events. But we're expecting these results to be published hopefully by spring 2025. And hopefully they will be another piece of like a starting point for further discussions about what should happen to really improve care for these women and to avoid future deaths for women who have social services involvement. So that's just in a nutshell. If there's any questions, I'm more than happy to take them at the end of this session. But yeah, thank you very much.
Thank you so much, Kat. So yes, before we have a little bit of space, I suppose, to hear reflections or comments or questions, I just wanted to kind of summarise where we think, where birth companions think, you know, we need to head from here on in. I've been very clear that we absolutely want to be part of driving forwards on a national health and social care pathway for women and families in this situation. There's a great model that exists for this, I believe, in the form of the National Bereavement Care Pathway. But what would be so critical about maybe taking some learnings from the impact that pathway has had in maternity care and moving it into this space is that it would be something that sits across health and social care to make sure that there is clear, consistent national policy and guidance, that there are shared toolkits and frameworks, and that there is a sort of community of support across the country to drive forward a different and hopefully far better model of care. But also as part of that, it's really fundamental that social care involvement in the 1001 days from conception to a child's second birthday is considered specifically in all relevant policies. This is not just about health and social care, of course. So, for instance, where policies are developed and shaped around women's involvement in the criminal justice system, it is really critical that we think about how the criminal justice system impacts mothers who are caring for children up to the age of 2 or who are separated from those children. And we published a spotlight paper on the dual contact that many women experience between the criminal justice system and the social care system recently. Many women in the immigration system are affected by social services involvement as well, or are incredibly fearful of social services involvement. So work being done to support migrant women, and we'll pick this up in our next reflections event, needs to recognise the specific issues around the 1001 days and social care. Also thinking about violence against women and girls, as I said earlier, many of the women who experience social care involvement for their own children have been victims of and survivors of abuse themselves, and also many of them have been in the care system or very close to it in their own childhoods. So we need to think about those linkages and make sure that policy being developed in those spaces recognises the crossover with pregnancy and early motherhood too. Mental health provision, we've talked about drug and alcohol services. These are all systems and services that are in flux, that have suffered quite significantly in recent years. What's great is that there is so much energy and change underway with a new government coming in and looking at all of these things. But we'll have a real missed opportunity if we don't think about the way that pregnant women and new mothers experience those as well. Housing is a really, really critical issue, and we could do a whole session specifically on that. And also child poverty. We know that the Child Poverty Task Force is up and running, and I sincerely hope that with pregnant women and mothers of babies are being considered in the round as part of that work. So we'd love to open it up for a little bit of discussion or reflection if there are people that would like to add things in the chat. I haven't been able to keep an eye on that while we've been talking, but Catherine, I think that you have. So I don't know whether there's anything we want to pick up on. Equally, if you would like to ask a question, we can take it now. I can see that there are some things in there. So Catherine, I'll come to you. And Kat, if you're able to rejoin us as well, then maybe we can respond where appropriate.
So I can see a few things, new things are starting to come in, but from earlier in this session, we actually had a couple of questions related to young women who have a care experience themselves. So Helen Perry has asked about, have we considered the young women who experience stillbirth when they themselves have been care experienced? And then we've also got a question from Georgia, sorry, it's just loading up, Stevenson, I believe, who was asking, let me wait for it to load up properly. I did have it a moment ago. It doesn't appear to be loading. She was asking, I'll try and summarize, a question about have we spoken to women about their own experiences of children's social care as children and how that impacts their later experience of pregnancy and birth when social services get involved. So a kind of theme there around care experienced young women.
Yeah, that's a very, very strong cycle, you know, unfortunately, and I mentioned earlier about the need to kind of break some of the cycles. We've been having some great conversations recently with Department of Health and Social Care and Department for Education, who are, you know, doing a review around the health needs of children who enter the care system, and I think joining those dots is just so important, not only because women who are care experienced bring all of that to their engagement with services later in life, including maternity care, but also because we know that where support can be put in place to avoid children entering the care system themselves, and to safely support families, that is the preferred option to interrupt those intergenerational kind of cycles. So I think that's really critical, specifically around stillbirth when among care experienced women and girls. I think that's a really, really good question, and again that speaks to why we need to think about these issues in the round. We need to think about the way that maternity care, for instance, is equipped to support care experienced women generally, even if they don't have social care involvement for their current baby. So yeah, it's really about joining the dots. Kat, I don't know if there's anything that you want to add from the research you've been doing recently.
There's a lot that's like the few questions that have been put forward in terms of young girls or young women becoming pregnant and having age appropriate resources to be signposted. I think that's definitely something that we've picked up, that some of the resources that young girls or young women during pregnancy are signposted to are not always age appropriate, especially when it comes to having a pregnancy loss or a stillbirth or a neonatal loss, that the resources that are then put forward to these young women are not always the ones that are most helpful, or the signposting to certain charities in terms of pregnancy loss are not always the most suitable for that age remit, and perhaps are more suitable for women in a slightly older age category. So that's definitely something that we've seen as well. I also made a note about having been in care of women who, or pregnant people who are care experienced. It's definitely something that we've seen in the different strands of the research, time and time again. And when I, for instance, conducted interviews with women who had a baby removed shortly after birth, it was one of the things that the advisory panel on the study was very, very passionate about, that they basically said you can't see the pregnancy as a starting point, because so much has happened before these women do become pregnant that will absolutely have an impact on how these women engage with healthcare professionals, how they will engage with social care during that pregnancy, that you have to take that into account. But unfortunately, that is not always the case. Pregnancy often is very much seen as a starting point, and all that previous trauma, all those previous life experiences are not always taken into account when providing care, which should be trauma-informed and personalised. Currently, the resources and the pressures on the system are not always are such that that's not always possible to provide, and it's having such detrimental impact on especially women who have been care experienced themselves. So yes, these are absolutely crucial issues that we've seen from the research as well, and it's very right to point them out as part of these reflections.
Thank you, Kat. I saw Polly Radcliffe had a hand up that has now gone down. I can unmute you to ask a question out loud if you'd like to put your hand up again. But I also have a question here in the chat from, there's Polly's got a hand up. I'll unmute you now and we'll come back to Ben's question in a minute. Hi, Polly. I think you can ask a question now.
I think Polly has to unmute herself now, because I think you've given her permission, but she might need to unmute herself.
Apologies, sorry. Yeah. Thank you so much for all your presentations. Really fascinating and real overlaps with our recent study, the Stepping Stone study that I've been in touch with Kirsty and Kat around our early findings for. One of the things that, the women that we interviewed for our longitudinal study was that one of the things that came across was that they the sort of integrated care pathways that exist are around data information sharing and kind of surveillance, so that there feels like there's integrated surveillance rather than a feeling of care. And I think, I mean, something that as kind of part of our findings has come up, is that the kind of child protection lens is one that and the kind of focus on women as in terms of risk, and rather than prevent early care and prevention, has a really detrimental impact in terms of engaging with services prenatally, particularly. And I mean, it's really important to bring social work into the room of that. And I mean, I know that I saw that somebody is in the meeting from Hertfordshire, and I know that there are alternative models that move away from a focus on risk. And I think that's a really important part of the conversation to be had.
I couldn't agree more, Polly, as you would expect me to say, because I can't wait for people to be able to see and engage with the Stepping Stone study, because I think it's a really, really important addition to the evidence around this. My own reflection just on what you've said would be that there was some really interesting stuff that came out of the independent review of children's social care around that management of the risk approach, and potentially the differentiation between early help and support and protection, but we're kind of yet to see where that sits now moving forwards. So a lot to think about there, and I know that attitudes to risk and varying approaches are a subject of CAT's research as well. So I think it's a really, really important area. Again, a really good reason as well to have some national consistency around this, because certainly the research that the Nuffield Family Justice Observatory have done around regional variation in the nature of care proceedings, the outcomes of care proceedings in infancy, and the drivers for those show that there is a lot of variation. There are some pockets of really excellent practice, but at the moment it does very much boil down to where you live in terms of what you can access.
Thank you, Polly. I can see in the chat that Ben has asked a question that a few people are engaging with already, but I'll put it to you, Kirsty, Kat, and Naomi. On mental health, one of the challenges we face across mental health is a narrow view of the sort of support people need, and a reliance on a limited range of traditional services which cannot easily be expanded and resourced. So I'm wondering what the alternatives might be for mums who are involved with children's social care, maybe peer support workers, group support. My concern is that unless we think differently on how to support these mums, we will always be frustrated by lack of resources and inaccessible mental health services. Would welcome your thoughts.
Naomi, do you want to take that one, or?
I mean, I'll take part of that. Yeah, I mean, it's a brilliant question, and one aspect of my response would be that I think if we can remove or try to lessen the inequity within the systems that are acting upon women on their babies and families in the first place, then that will actually have some impact on women's experience of mental ill health and distress, because some of what they're experiencing arises from their experiences with those systems and the inequities that come out of that, the lack of justice, the feelings that they're not being listened to, the feelings that they're not being properly supported. So I do think that's a really important aspect of it, and also to understand that that women's experiences of trauma in their past and in their present also act upon how they experience what they're experiencing throughout their contact with children's social care in this period. And if we are able to improve our trauma-informed way of working across universal systems, that this is actually going to act particularly well upon those women who have experienced the significant traumas that we know impact on this particular group. Not only that, I think it's going to be good for women much more generally. So I think that's also a really important focus. I'll hand back to Kirsty and Kat perhaps to talk about other forms of support around mental ill health and distress.
Yeah, thank you.
Sorry, Kirsty.
I was just going to say, Kat, please do.
So the question made me smile, because it's exactly the question I put to the women during the qualitative interviews I conducted. And I completely echo what Naomi's saying in terms of specialist services and the barriers that women who go through having their infant separated from them, often they're no longer eligible for certain specialist mental health services that they perhaps previously were eligible to. I'm thinking of perinatal mental health services in particular. Surprisingly, when I asked women this question, like what would have helped during your pregnancy or after your baby was removed, what would have helped you the most? They didn't say anything about secondary mental health services. They said almost simple things like kindness and having people taken an interest in how they were doing. And the things that they mentioned were not the things that would necessarily cost a lot, but these were responses from women who were desperate for somebody sort of taking 5 minutes out of their shift on a postnatal ward to make them a cup of tea and ask them, how are you generally feeling? Can I do something for you? Can I take a picture of you and your baby? Like small acts of kindness that would have made a huge impact on the overall experience of these women. And I'm not saying this to minimize any of the huge efforts that are taking place currently to really improve services for these women. But I think if we manage the small acts of kindness in universal services, that's a huge win that is not requiring a lot of resources and a lot of additional input in terms of money, but potentially has a huge impact on women's overall experience already. So yeah,
I think that double-sided approach to it, the big structural stuff that needs to happen, and the sort of granular moments of interaction are together so powerful. I mean, an obvious response to the point that you make, Ben, is this is what we're trying to model and understand in the ISI project in Hackney. We know that we can provide excellent services for these women, but we want to draw out, what are the bits of that provision that are replicable in other places. How do you shape that provision so it's appropriate for a local population, but what can you draw out of it for national learning? And I think the relationship is absolutely crucial to that. The relationships that women are supported to form with people that allow them to rebuild trust in services and that allow services to provide care and support that is appropriate is really, really key. The only thing that I would add is that I think we do know that this can work. It has worked in all spaces. There's a member of our lived experience team who talks incredibly powerfully about the relationships that she had with a midwife and with several social workers, quite some time ago, that really did help her, that made a huge difference to her and her baby. And she's also seen some incredibly difficult, challenging, negative practice. But it is possible, and the answer is it's quite often different for different women. So we need to be able to engage with what individual women need. So we need systems that can respond to that.
Thanks, Kirsty. I think we've got enough time for a couple more questions. Helen, I can see your hand is up, so I will unmute you in just a minute after we've listened answered Anna's question. This is going back to the MBRRACE data itself. She asks, as well as how to support mums, how is this data being used to inform policy of child removal itself? Is there data on how many of the deaths resulted in coroners producing prevention of future deaths reports and what these recommended?
Pat, I'm not sure if there's anything from the current recent work that you've been doing that speaks to that. I mean, I would just say a big priority for us is to make sure that this qualitative and quantitative evidence feeds into change in practice across the board. And there are some, serious case reviews and certainly some inquests that hold valuable learning around that. But Kat, I'm not sure if there's anything.
I must admit, I was frantically trying to read up on all the comments at the same time, so I might have been slightly distracted when, Catherine, you read the question. Sorry, can you repeat it again?
Of course, I'll just find that one again. So it was about the data and how it's used, not just to support mums, but also to inform the policy around child removals themselves. And is there any data or insights from deaths that go on to have coroners produce a prevention of future deaths report? Insights from those recommendations.
So from my understanding how the MBRRACE process works is that when there is a maternal death, it's very much recommended that there is a coroner's investigation. And as part of the MBRRACE data, often the coroner's report is included. I'm not fully up to speed with what is done with coroner's report in terms of further investigations. Sometimes when a woman dies by homicide, there is a homicide review, and that tends to not be included for confidentiality purposes. But it is, I think that the depth of the study that we've done, looking in depth into these 47 cases, and I can say, so these case notes were vast, so they included all of the maternity records, sometimes GP records, police records, social care records. So there was a lot to trawl through to understand the care journey of these women, and understanding also their postnatal episodes where they perhaps had admissions to an emergency department, etc., was just to really understand what a care journey for a woman with social services involvement might look like. And I think the power of the results, and Kirsty, you've been sort of involved in sort of doing some of the sense checking of the findings. I would hope that when we come to writing this up as policy recommendations, and that is fed to the relevant departments and relevant stakeholders, that really has some power and some impact to reflect on what some of these women are expected to achieve. And I'm saying that because my impression from these preliminary findings is that the expectations of women who are well off, well supported, employed, have their lives together, is attend an XYZ number of appointments. But when it comes to women who are really struggling in life, have lots to juggle, have lots to hold in mind in terms of their finance, their housing, difficult relationships, traumatic pasts, fractured family dynamics, you name it, all of that takes a lot of headspace. And then these women, the reality is that these women have a multitude of appointments, not just from within health, but also with social care, perhaps with mental health service, and the bar is higher, is put much higher in terms of appointment schedules, etc. So I think if we can really rethink some of these care journeys and care pathways to make it easier for women to meet that expectation, I think that would be a huge stride forward in making this, like the care for some of these women, better, easier accessible, easy to engage with in the whole run. And hopefully that will have much better outcomes, not just for the mum, but also for the baby, and keeping them together.
Thank you, Kat. I was going to go now to Helen, but I think we've run out of time to have one more question, unless Kirsty and Amy, you'd like to.
I'd love to hear what Helen has to say, if it's, and then we can round up. Yeah.
Helen, you've got permissions to unmute now if you would still like to. I'm not sure if that's working. I can see your hand's gone down, Helen, but
Are you able to unmute, Helen? Otherwise we'll round up and hope that we get to have a conversation with you separately. There's so much more in the chat as well that I would love us to discuss, but it just, I suppose it reaffirms why we. Oh, Helen, are you unmuting?
Yeah, sorry, I tried and it wouldn't happen, and now it has. I'd just like to say thank you so much, because it's amazing and refreshing to hear this, because we've been doing this in Wales for some time, and I know we're going to be linking up with you. But one of the things I wanted to bring up, that the young women, we find that there is a lack of just their care for them as their human rights. So the concern we have is very often we've had young women who were brought into meetings within an hour of giving birth, and actually they haven't even had a chance to have a shower. And then I was wondering if you'd had any opportunity to look at the mother and baby units, because we have huge concerns around those. From what I can, we've also worked with the prison service, because we also have young women in the criminal justice system. And what we're finding out is that the mother and baby units don't even have the same human rights as a prison. And I've got, there's so much I'm sure we can link up on, but I just wanted to say thank you. And Kat, I absolutely agree. There's so much just being that kind person. So thank you for today anyway.
Thank you so much. What a good note to round off on. We are absolutely going to be linking up, Helen, and I'm really pleased to see some talk about what's happening in the devolved nations in the chat, because that is a set of conversations that we're really keen to pursue. So we'll be picking those up. Crossovers with mother and baby units in prison and out in the community are a big piece of work that we're really keen to do. So we'll look forward to speaking to you about that. Thank you so much to everybody for joining us today. I was just going to say before Helen posed her question that the amount in the chat is just affirming our sense that it was valuable to bring everyone together and to really just hone in on this part of the MBRRACE report. There is so much in that report every year, but this is a story that I think MBRRACE has been really important in helping to build and construct and bring some attention to. So thank you very much. And if you want to stay in touch with what we're doing in this space and with Kat's work, please do sign up for our newsletter. Catherine's just put the link in the chat, and we'll circulate it with the slides after today as well. So yeah, thank you.
Thanks everyone. Bye.